Hello everyone, and welcome to CK Med. My name is Clark, and I'm going to be taking you through liver and biliary infections today. I'm going to shout out to Nikki Shaw for creating the backbones of this PowerPoint, as I've adapted it and added extra details that are important for your exams and for your step 1. So without further ado, we're going to jump right into our viral infections of the liver, including hepatitis A through E, and then onto our parasitic infections of the liver and biliary tree.
So to start things off, you need to understand what is hepatitis. So hepatitis is an infection of the liver, and specifically viral infection of the liver, and it takes kind of two different forms, an acute infection and a chronic infection. And with either one, how it kind of presents is in two stages, the pre-icteric stage or the prodromal stage and the icteric. And it's very, very important, very tricky. Right? I could write a very hard question giving you someone that has hepatitis, but in the stem, they're in the pre-icteric stage. Why? Is because in the pre-icteric stage, they don't have jaundice. So it doesn't really give away as easily what this person has, right? Someone comes in with fever, fatigue, joint pain, abdominal pain, malaise, some vomiting. With those symptoms, it just means this person is ill, probably digestive system related, and you don't really have anything that you can diagnose, right? The joint and knee pain is kind of a little bit more specific, but that's, again, in a lot of infections, and so it's not really that helpful. However, if you see something like this, like discussed in cigarette smoke and the smell of smoke, this is more specific to hepatitis B and C, but it can be in A and E and D. But that's something that's really weird, and you don't see that really in many other infections. And so this kind of can jump your viral hepatitis infections up to the top of your differential list, right? And then if they progress into the icteric stage, they start having jaundice, right? That's because we've now damaged your liver cells, and that it has released our conjugated and backed up our unconjugated bilirubin. That this person is starting to turn yellow, just like Big Bird over here, right? Jaundice, maybe you should get that checked out, right? You also will see elevated ALT and AST, as you've probably learned in your biochemistry class. And again, because we're damaging the liver tissue itself and not blocking up stuff it's trying to spit out, such as in the biliary tree, we're not going to see a rise in ALP or GGT, which are more specific to obstruction, right? If you see those two, it's probably due to obstruction, or some of the infections will be coming up on in just a few minutes. Again, for specific diagnostic for the viruses, definitely we're going to be doing ELISAs for these guys. And then hepatitis B has its own little thing. So we want to look for anti-HAV for hepatitis A and HCV IgM and IgG for hepatitis C. And we know that because we have viral infections, our viruses replicate inside cells, and when they're replicating inside cells, they get broken up and little pieces of their proteins float around the cytosol, get chopped up, and then presented on MHC class 1. So we know that our CD8 T cells, right, or our cytotoxic CTL T cells, are the ones that are going to be responding and killing these cells. And so in response, not only from the virus damaging our cells, and then over-proliferating and finding a bunch of viral protein in the cytosol, there's also going to be death of these cells because of CD8 T cells, and that's one of the things we'll see on histology that I'll be describing in just a second. So our first hepatitis virus, I know these are really kind of boring. It's not anything really fun that we can discuss through them, but there are a few high yield points, and they're very straightforward, that once you can recognize this on a stem, you're going to have your diagnosis and be able to answer the questions accordingly. So again, here we are. This is our first infection, hepatitis A virus. And what did I say? Every time we want to go back to what are the basics. So this is one of our Percorna viruses. That means it is positive single-stranded RNA virus, and it's associated with echovirus, rhinovirus, and a couple others, as we will approach in different modules. It has icosahedral shape, and it does not have an envelope, meaning that it's naked and it is acid stable. So when you ingest this, it's going to survive in the stomach acid and make its way into the intestines, and then make its way into the bloodstream, and guess what? Here we are, liver hepatitis, right? And so that's pretty much how this guy comes into play. So where do we get this from? So we usually get this from a fecal oral transmission. And so can you think of who most commonly is going to be associated with fecal oral transmission? Well, hopefully you're thinking of children, because they're the ones that are kind of wiping their butts or itching their butts in their pants and then maybe smelling it or licking and tasting it. And that's how we get our hepatitis viruses, or sharing it with someone next to them. That's a common place where you find this is in daycare centers. So you can find this in outbreaks. In addition, nasty college teenagers, 18-year-olds and stuff like that in colleges is another place that you'll find outbreaks. In addition to restaurants serving things like shellfish, hepatitis A virus can be found in a lot of shellfish. So keep that in mind as a possible etiology for this. Usually this is asymptomatic. It just progresses. They might feel a little bit ill and it goes away. However, you can still have that icteric stage, so this person can come in very jaundiced and yellow and stuff like that. It only lasts a couple weeks, goes away. That's probably your hepatitis A virus, especially if they were eating shellfish or they're associated in daycare setting and stuff like that. For diagnosis, we talked about that, the antibodies of IgM against hepatitis A virus. Specifically, things that you can look on histology, I put this isn't super high yield, but sometimes they like differentiate the words. It could be like a one question thing that could come up about hepatitis virus. What are you going to find? So like I mentioned, you're having your CD8 T cells come in and they want to kill these cells. So what they do is they associate themselves with the fast ligand and fast ligand pathway, which triggers apoptosis. And apoptosis can be found in these cells here. These are known as Councilman bodies or apoptotic bodies. They're very pink and eosinophilic compared to the other hepatocytes that I'm circling right there. Other things that you can find are monocytes and lymphocytes founding within there. And then the hepatocytes, some of them swell like I have circled in addition to these guys. Those are a lot larger than normal. And that's kind of more specific to your hepatitis A or hepatitis E viruses. They look just like that. Hepatitis B, on the other hand, this guy is a booger, right? So hepatitis B is for booger. No, I'm just kidding. That's a terrible mnemonic. But this is something you need to know pretty much everything about. This is the most high-yield hepatitis virus, is because I can write 57 million questions just on this virus alone. How does it present? How does it look like on histology? What is the name of the particle? What is the serology for the different types of infections? What type of genome does this have? What group of Baltimore classification? All those things can come up in questions. So keep this in mind. Definitely put this on the top of your priority list when you're studying hepatitis viruses. So this is group 7. This is the only virus found within group 7 of your Baltimore classification, meaning it has partially double-stranded DNA. It's in a circular form. And it is known as your Hepadnaviridae, or also HepaDNA virus is what that means. The virion, a complete virus and replicating and working virus, this is known as your Dane particle. I really don't know how high yield that is, but it has shown up in some practice question stems I have seen. So keep in mind that this is called the Dane particle. And things you should definitely know are the antigens. Right? There's going to be 3 antigen types that you're going to find within this virus, and you need to know not only what they are, but what they mean. So hepatitis has the outer surface is this pink guy out here. This is known as your HBs antigen or surface antigen. It is a glycoprotein. Pretty much it attaches an envelope to the core. And it's very important because it's the earliest thing that we find in acute infection. Even before symptoms appear, we're going to be able to find this if someone is exposed and it gets into their bloodstream. We can find this surface antigen. It's also present in chronic infection, and we'll be describing each of those types of infections in just a second. Another antigen is this guy. This is your E or envelope. It's not really an envelope antigen. I like to call it envelope, but it's really a matrix protein that holds your surface antigen to your core antigen. It's this little star guy right here. And it just holds those two together. That's not important. It's just knowing that you should know that your E antigen is an indicator of infectivity. It's pretty much how infectious is this person. So if you have a woman who's pregnant, she comes in and says, I'm an IV drug user, I have abdominal pain and jaundice, and I most likely have hepatitis B, how likely am I to pass this on to my child, right? And the first thing I would say, okay, yes, let me do your serology and check. Yes, you are infected. You have surface antigen of this in your blood. You probably have hepatitis B, most likely, very high specificity. However, in order to answer this patient's question, she said, how likely am I to pass it on to my child? Well, at that point, I would have to check for HBe antigen. This says that it is replicating and working virus, that it's not latent, that it's just working. And at that point, that means it is infective. So if she has a positive for HBe antigen, she is very likely to pass this on to her baby. And that is the importance of that. Another guy is your core antigen. This is only found during infection. This is not present when you vaccinate the person to hepatitis B, and I'll be explaining what that vaccine is in just a second. So keep in mind, C antigen means infected, and antibodies against this antigen means infected, or they were infected, depending on what stage we're talking about. So now on to the serology for hepatitis B. This is very important and very high yield. You should definitely know how to analyze different infections. I've made a chart down here that pretty much sums up where you could possibly get questions from on your microbiology exams, in addition to step 1. So like we mentioned on the last slide, we pointed out that our HBs surface antigen will be the first thing to rise during an infection of hepatitis B. So we can see this rises up to a certain peak, and at that point, during an acute infection, we start making antibodies against our surface antigen. First IgM, and then IgG is most important. Once we start making those antibodies, it starts neutralizing this surface antigen, and this is why we have this kind of decline right here. There's a certain point that we reach that our equipment measuring surface antigen and our equipment measuring antibodies against surface antigen can no longer detect them. Why? Is because we have a certain amount of neutralization occurring. So what happens is we have our certain antigen up here. I'm going to draw it in this little picture. Say we have 4 molecules of antigen, right? And if that was the only thing floating there, I can say I can now measure that we have 4 pieces of surface antigen. That's one of our measurements. However, if we start making antibodies against this antigen, we can see that we can start neutralizing our antigens here to the point now that if I were to measure my surface antigen, now I only have 2 out of the 4 being red. And this can continue until we can pretty much entirely neutralize our surface antigen. Now, if I were to go and measure my surface antigen, I'd have 0 present, right? If I were to individually measure how much antibody I have by themselves, it just does the opposite, right? So I have 1 antibody by themselves, say it's not bound here, and I can measure 1, and then 2, and 3, and 4. But once they bind together, now I no longer can measure my 1, 2, 3, 4 antibodies by themselves. So you can see that both the surface antigen measurement and the surface antigen antibody, or anti-HBs antibodies, will both go negative, right? Or 0, undetectable. And so this period that this neutralization is occurring is this one right here, and it's known as your window period or core windows. This is very important to recognize when this person is in the window period, right? And just knowing that it's negative for both is not enough. If someone is not exposed to hepatitis B, they should not have antibodies, and they should not have the surface antigen in them. So this is also the same result in someone that hasn't been infected with hepatitis B, right? However, what determines that this person is actually infected with hepatitis B, but in the window period, is a positive anti-HBC antibody. So this is very high yield to know the window period and what it looks like. And I kind of drew this out. You're going to have a negative surface antigen. You'll have a negative antibody for that surface antigen, yet you'll have a positive HBC IgM present. And this person is an acute infection during the window period. Once that surface antigen is cleared, we've pretty much cleared this infection, and now our antibodies can go and be free by themselves over here. and we can then measure them in serum, and this person has been cleared of infection. So this is someone, several months, years after they've been infected with the virus. And how we can tell this person was resolved of an infection is the presence of our surface antibodies, but then that they were resolving an infection rather than just our immunization is our HBC. So let's look down at our chart and kind of analyze what I'm talking about right now. So if someone is in an initial acute infection, I'm going to see my surface antigen being positive, right? In addition, at this point, I haven't started making my antibodies against that surface antigen, so that will be negative. But I have started making my early stage anti-HBC IgM, and you can see that right here as being positive. So you can see both of those rising. So say we're right here. Correct? Then at a point, we start neutralizing our surface antigen with the new antibody. We're making our surface antibody, and we go into the window period where we are negative for surface antigen, negative for anti-HBS, but still positive for our core antibody. Then, once this resolves of an acute infection, the surface antigen entirely disappears right here. We will have antibodies rise to where we can measure them, so those will now be positive. And because this was an infection, meaning the Dane particle, we had our core antigen that we can make antibodies against, and that is still positive. So now this is someone who is resolved. However, let's say we get to a point where someone's immune system is not very strong. They weren't making enough antibodies towards the surface antigen to the point where the infection is progressing into chronic stage. At that point, we're going to see a positive surface antigen, right? Because we don't make enough antibodies to neutralize them. So this antigen will be present and continuously being produced and secreted out into serum. So we can measure that being positive. And here's the major problem right here as I'm circling this. This is the problem that leads to chronic infection, is we're not making enough great antibodies against the virus, and that leads to this virus continually to replicate and infect the person. In addition, how I can tell this is a chronic infection, now imagine you've made antibodies to HBC. Initially, they're IgM. Over a course of time, if we keep stimulating the immune system with our core antigen floating around, at that point we stimulate the class switching to IgG, and that's why we can have this being positive. And so this just means we've been at it for a long time. This person has been infected for a long time. You put those two words together, that is known as chronic infection. And then one other thing that you definitely need to be knowing, and very, very high yield, is knowing what the vaccination status and what that looks like. So if this person is introduced with only surface antigen, not core antigen, not our E antigen, not the genome, nothing, it's just surface antigen, which is this purple right here, emphasizing, I'm circling up here, this purple out here. If that's the only thing that's floating, right? So let me draw the surface antigen. If that's the only thing floating out here, I'm only going to make antibodies towards that thing. So obviously this isn't replicating, so it's not a problem. We're not causing any symptoms necessarily. And at that point, we have zero surface antigen after 6 months. So say I've infected this person, well, not really infected, but injected our surface antigen into this person through vaccination. Over a course of time, this is going to disappear, and so that will be negative. And then guess what we're going to find? We're going to find antibodies against that, and then we will not find any core antibodies. Why? The core wasn't in the vaccine. You can't have antibodies made against something that's never been there to trigger the antibodies being made to them, right? So if the core antigen isn't in the vaccine, we're not making antibodies against them, so they're both negative, IgM and IgG. That person has been vaccinated and is no longer susceptible to hepatitis B infection. Now, if this person was never vaccinated and never had an infection, right? They're not in that resolved acute infection stage. They don't have antibodies floating around for core antigen or surface antigen. And obviously, since the virus isn't in them, they don't have surface antigen itself being present. So we're kind of this triple or quadruple negative down here. That means this person is susceptible or at risk of contracting the virus. And you might ask yourself, why the heck should I know that? That they would never ask that. Actually, they will. That's very high yield to know what a person that is susceptible. You have to know it in those words, right? That could be an option that you could cross off if someone has a positive on one of these things, which really helps you out. You can cross off an answer, make your answer more likely. But often they ask questions showing a status just like this, and they ask, what is this person's status in regards to hepatitis B? They are susceptible. This is very high yield to know. And over here is just another picture kind of emphasizing what it looks like for chronic infection, right? So we start making our IgM against HBC, those clear, and we start making our IgG, which is this guy right up here, to the point where we have HBC and are positive of our surface antigen for a long amount of time, months and months and months. We know this person is in a chronic infection because there's no resolution. When you see resolution, what's the marker for resolution? Antibodies to HBs. That is the marker that we use for being resolved of an infection of hepatitis B. So these guys are super high yield. Definitely maybe watch this a couple times if you didn't get it on the first time. Definitely watch Sketchy and then go back to your notes, and this should be very, very clear for you. Maybe draw it out, teach a couple people. Once you do that, you're not going to miss any of these questions, and they'll be very straightforward from that point on. So now on to a little bit more about what is hepatitis B and where we get it, since we talked about serology now. Pretty much the transmission is involving blood, and most commonly actually is more like sexually transmitted. So keep in mind that baby making, right? So this is your kind of 3 Bs, right? Blood, baby making, and birthing. But however, baby making is the most important of these guys as far as hepatitis B goes. IV drug use, you can also get it from, however, that's more commonly associated with hepatitis C. So pathogenesis, pretty much the hepatitis B virus goes into the cell, it undergoes reverse transcription using its own reverse transcriptase, and then integrates itself into the genome. Now, usually it hangs around in the nucleus for a while, maybe a few months. If this then progresses to a chronic infection, then integration occurs, and that is why a chronic infection can be associated with hepatocellular carcinoma, or HCC. So a very small amount of hepatitis B infected patients actually make it to chronic, so 15 to 30%. So if you're asked a question, someone's infected with hepatitis B, they show you the serology, and you have to tell the patient what is most likely outcome of this. Obviously, since you know that 15 to 30% is chronic, that means up to 70% actually is just acute and they'll be resolved. That is your answer. It'll be an acute infection. You'll be fine in a few weeks. Have a nice day, right? And then only a small percentage of those 15 to 30% actually then progress to hepatocellular carcinoma, and that is because we have damage, cirrhosis of the liver, in addition, that integration of the genome. That can lead to hepatocellular carcinoma. So diagnosis is serology. We can do histology as well. This is something that we find are granular eosinophilic ground glass appearance in the cytosol. So this is very smooth, shiny. These are pretty much just tons of viral particles within the cytosol of this hepatocyte. And then in addition, we have damage and killing of our hepatocytes due to our cytotoxic T cells. So that pretty much sums up our hepatitis B virus. So now on to our last few. So hepatitis C is another guy that's very important. You have to know that this is differing from hepatitis B as far as the genome. It has an envelope. It is positive single-stranded RNA virus. This is one of your flaviviruses, Flava Flav, right? So that's your high C drink. Flava Flav. So transmission from this most commonly is IV drug use. You can get it from tattoos and transfusions, or it used to occur in transfusions. So back in the 1900s, we had a war known as the Vietnam War, and a lot of veterans actually contracted this hepatitis C virus through drugs in addition to transfusions, because a lot of them were being shot, they're having their legs blown off and those sorts of things, and needed blood transfusions. And we didn't check for this virus because it wasn't rampant, it wasn't crazy, and that's how a lot of our veterans in the VA hospitals in the United States, actually you might see them in the GI clinic and such like that, because they have chronic hepatitis and cirrhosis, and that actually leads to their eventual death because of liver failure. But it was commonly in veterans having this hepatitis C in the United States due to those transfusions, unfortunately. But now we screen that in our transfusion blood, or in transfused blood, and plasma, so that we do not give this to our patients. Virulence pretty much inhibits apoptosis and inhibits your interferon alpha action, which pretty much interferon alpha, what it does is it can stimulate cell death, but also, most importantly, it stimulates the production and upregulation of MHC1 class molecules so that your CD8 T cells can come and respond to it. And if this blocks it, therefore not presenting your MHC class 1, our CD8 T cells are not going to know that our hepatocytes are infected with hepatitis C. However, there are going to be some cells that are going to be presenting still, and we will have a lymphoid aggregate response, as you can see over in histology. This is the one big guy over here, is that we have lymphoid aggregates in addition to damage causing hepatic steatosis or macrovesicular steatosis right next to that. You see those two things put together, that's going to be hepatitis C, and it's very actually specific for it. Most commonly, the vast majority of patients that get hepatitis C are going to continue into chronic hepatitis and eventually cirrhosis and possibly HCC as well. We don't make a vaccine to this, as it's really hard. Why? Is because its RNA polymerase keeps making all these faulty pieces, and we keep throwing off these different antigens that we keep making up proteins. Pretty much this thing just makes up whatever, right? It's confabulating random virion particles floating around. So our immune system doesn't know what to do and doesn't know what to respond appropriately, as to why this can lead to chronic infection most commonly. Diagnosis is ELISA, looking for the antibody, and then gold standard is PCR for the hepatitis virus itself. And now on to hepatitis D. This guy is a negative single-stranded RNA. It's associated with hepatitis B. It cannot grow or replicate without hepatitis B. Why? Is because it requires surface antigen, like we discussed with hepatitis B, in order for this to replicate. So this is known as a satellite virus. So let's say we have hepatitis D virus. This is kind of the smooth circle. That is an absolute terrible circle, but that is the smooth circle. Just pretend it's smooth or something like that. Okay, that's a smooth circle, right? And then we have our surface antigen of our hepatitis B virus here, which is this kind of jaggedy edge, right? And it goes into a cell, and then it breaks up and makes new virions. So this is our hepatitis D. So now we make this hepatitis D smooth antigen, and in order for this to even get into the cell in the first place, it required this little key found on our hepatitis B surface antigen. Now, let's say this person is not infected with hepatitis B and they just get hepatitis D. We've now made new smooth virions, but guess what? Hepatitis B is not present to give the surface antigen. So when these guys spit out and want to reinfect new cells over here, they can't. They don't have that key. They don't have that surface antigen surrounding them. And so this ends and the infection is done. Right? However, if this person is infected with hepatitis B, it can continue to make and cover these guys with surface antigens so that they can go and reinfect more cells. So that's why these kind of viruses go together. Hepatitis B and D go together. D is reliant on hepatitis B in order to work. This is known as a satellite or dependent virus. Is a very important concept for you to understand. So now that we know that these two infections have to kind of work together, we can describe them in two different ways, a superinfection versus co-infection. So superinfection, this is worse. It's a lot worse. Why? Is because this person already has had chronic hepatitis B. Remember, this is only up to 30% of patients, so it's unlikely that this even occurs in people in reality. But if someone has chronic hepatitis B virus, then we throw in hepatitis D, this can cause what is known as a superinfection. It causes fulminant or almost immediate cirrhosis and hepatic encephalopathy and liver failure, and most likely death in that case. Where co-infection, let's say we throw in hepatitis B and D at the same time. At this point, they kind of progress together. It can lead to chronicity, but less likely, and usually just is an acute infection and resolves similar to hepatitis B. And that's pretty much what a co-infection is. If there's chronic stage, similar to hepatitis D, again, hepatocellular carcinoma is possible. You'll have the same histology that we talked about in hepatitis B, that ground glass cytosol. And then how do we protect from hepatitis D? So they could describe a virus that's reliant on hepatitis B surface antigen, meaning they're talking about hepatitis D as in dog. And at that point they say, oh, well, we can see that we give a vaccine towards another virus and the incidence of this one we're talking about also goes down. That is when we're talking about giving the hepatitis B vaccine and how that protects against hepatitis D, right? If we block off hepatitis B, hepatitis D is not going to do anything, right? It's going to be blocked from its replication as well. So we kind of kill two birds with one stone with that immunization. So anti-vaxxers, actually, you should probably get your children vaccinated. And this is probably one of the reasons we definitely should. So hepatitis E virus is our last of our hepatitis viruses. Oh, thank the Lord. But it's very straightforward and a little bit worse than our hepatitis A virus. So the most important thing is knowing that it's a single-stranded RNA virus, that it's icosahedral and naked, very similar to your hepatitis A virus, meaning that it's acid stable. And so you can get this fecal-oral contamination, very similar to hepatitis A. Hopefully you guys know that hepatitis A is for acute, right? And hepatitis E is for acute, TM. Okay, so yes, for acute is also an acute infection. However, most important is that you should know that is very serious in pregnant women. Literally, the only thing I think I've seen questions in regards to hepatitis E virus is it's more dangerous HAV, especially in pregnant women, period. Like, I don't think I've seen any other questions in regards to this, other than maybe that it is another hepatitis virus that is acute that isn't hepatitis A, which makes sense. There's only two of them. And that pretty much closes off our viral infections of the liver. So we're going to cover these parasitic infections now. These guys are quite a bit more fun than our viral infections. So the first one is Fasciola hepatica or gigantica. And I just remember this is fasciola or fascinating foliage. Why is it foliage? Because it literally looks like a leaf. I couldn't make a fluke look more like a leaf than this guy. It looks straight up like a leaf, just plucked right off a tree. And that is your fascinating fasciola foliage. And this is known as the liver fluke. And pretty much where you get it from is from eating watercress or unwashed watercress. And it is in the form of the Metacercariae. I'm not sure how important knowing Metacercariae is here. However, watercress is very important to know. So what happens, this guy kind of makes its way into the duodenal wall, penetrates into the liver, and then enters the bile ducts and hangs out there. Obviously, if you have a bunch of flukes growing in your bile ducts, that can probably cause obstruction. And guess what you're going to present with? Obstructive jaundice. In addition, increase in ALP and GGT, liver enzymes, and bilirubin to cause that jaundice. Plus, due to inflammation and damage to your backing up of your liver, you'll have hepatomegaly, right upper quadrant. And in addition, the basic signs and symptoms of liver damage. Plus, because it's a worm, you'll see eosinophilia. And the basics of what we talked about is that biliary obstruction. This guy isn't super important to know as far as the likelihood of causing that biliary obstruction. This guy, on the other hand, is. So this is one of my favorite flukes that I will ever, or even organisms to come across, and I'll explain that right now. You're probably wondering why there is Charlie Chaplin down in the picture. And if you haven't noticed it, I'll give you a few seconds. Let's talk about this guy. This is known as your Chinese liver fluke, or Opisthorchis sinensis, or Clonorchis sinensis. This is found in Asia, or East Asia, and pretty much how you get it is from cooking or eating raw, uncooked freshwater fish. This is what he looks like as a fluke. That's not as important to be able to identify than the egg itself. And the infection pretty much causes hepatomegaly, like we discussed, jaundice, and it causes that biliary obstruction, like we discussed with fasciola. But this guy really increases and causes irritation of the biliary tree itself, to the point that it can actually lead to cholangiocarcinoma and biliary tract adenocarcinoma. This is very high yield, kind of hook between pathology and micro, to knowing how a fluke organism, right, something that you can get from etiology found in East Asia, to the point of having cholangiocarcinoma. That is a very kind of smooth connection between a location in the world to a pathology specific to what you can contract there. As far as the egg, pretty much why I have Charlie Chaplin here is if you can notice his little hat here, this kind of like top hat guy, you know, I can just imagine Charlie Chaplin doing a little dance. He's got ha-cha-cha-cha, ha-cha-cha-cha, right? So here's our little guy with our little Charlie Chaplin hat right here. See the little hat on him? Oh, so cute. And then he's got this little tail right here. He's a cute little bud. The second you see that picture, look for Opisthorchis sinensis. If you can't pronounce it, look for the word you can't pronounce as an answer option for diagnosis, and move on to the next question. I got about 80 seconds on my micro exam for that guy, so definitely keep that in mind. It is very, very important to know the images of our eggs. This is known as an embryonated egg in stool, and metacercariae is the infective stage. But that is your little top hat guy, or Charlie Chaplin, or Clonorchis Chaplin, right? And that's very important. So now we're going to discuss some of our hemorrhagic fevers. These guys, a couple of them are pretty high yield, and I'll just kind of breeze through some of the other guys so that we can get to the blood infections. So Ebola virus, I'm sure you've heard about it in the news in the last few years. Definitely not recently, I guess, but a few years ago there was an outbreak in West Africa that was quite rampant and quite hysteric to the people in the villages, thinking that doctors coming into the areas were here to steal their blood. Instead, they were trying to help and isolate this infection so more people didn't die. But everyone was telling them that they're coming in to steal your blood and your body and your family members. And so people started running off into the forest and escaping and not getting the help that they needed. So transmission for this guy is you can get it from fruit bats and pigs, primates, and even humans who have contracted the virus. So that's why I got these cute little bat guys up here. Oh, they're so cute. And it's pretty much just found in bushmen and hunters in Africa. There hasn't been really any outbreaks anywhere else. So pathogenesis for this isn't that important. Just to know that it is very damaging virus. So once it starts replicating in our cells, it starts kind of destroying everything. So tissue necrosis in the spleen and liver and lymph nodes, everything. It causes cytokine storm. And because endothelial cells start to separate due to not only cytokine storm, but also due to the CPE of the virus, or cytopathic effect, it starts leaking vasculature into tissues. And so that's why we call this a hemorrhagic fever. If the hemorrhage is severe enough, especially in internal organs, it can cause hypovolemic shock and death. In order to kind of separate it from Marburg, this usually has no rash. It's usually just bleeding from everything. It's not a rash necessarily. It usually takes about 12 days to pretty much die off from this. One of the first things you see is like a severe sore throat, which really doesn't help because someone that has strep throat can have a really severe sore throat. Someone that just contracted HIV can have a severe sore throat. So it doesn't really help. And so diagnosis is kind of looking for the virus itself, or seeing the later onset symptoms of hemorrhagic fever, plus epidemiology and history taking is most important to diagnose these guys as far as where you're going to find it, right? If I'm in Africa, I'm not going to be carrying around an RT-PCR or ELISA. That's something that you're going to have in the United States. So pretty much history is going to be able to diagnose this guy most importantly. So for Marburg, the difference pretty much comes down to that there's a rash. They wouldn't have you really pick between Marburg and Ebola unless they showed you a picture of the virus. So Ebola has this kind of long filamentous shape like this. Marburg does not look like that at all. It's kind of bullet shaped. It doesn't look like it at all. Sometimes it's longer and straight. Is what our Marburg virus looks like. But you can see bullae and vesicles on the arms that you can find in this guy. You don't really see that in Ebola very, very commonly. Crimean-Congo hemorrhagic fever. This is found in Africa and the Balkans. And it's carried by these weird ticks called hyaloma ticks. Pretty much the weird thing is that you have photophobia, neck stiffness, similar to what you're going to find in like CNS infections, such as like meningitis, right? Those are some of the presenting symptoms for meningitis. However, it actually isn't due to the virus actually being there itself. It actually is just due to bleeding into those areas that causes those symptoms. That you really don't need to know very high yield, but as long as you've heard the name, you should be able to point out the tick, which is the hyaloma ticks. Rift Valley fever. This is a segmented bunya virus. You might have heard this in Sketchy if you have watched this. It's found in Africa, or places in Africa. It's usually found associated with infected animals. So veterinarians are usually the ones that pick this up. It's usually asymptomatic, but can involve your eyes, encephalitis, hemorrhagic fever, like obviously this section is discussing. So a very small amount of patients actually go into hemorrhagic fever. It's usually permanent vision loss. This is one of common causes of viral vision loss. Other things are like CMV virus. Pretty much diagnosis with most of our viral infections are ELISA and PCR. Lassa fever is another thing I want to mention really quickly. This is one of your arenaviruses. So in Sketchy, you will come across those arenaviruses. And this is negative single-stranded RNA virus. It's found in places like Nigeria and Guinea and Sierra Leone and Liberia, Ghana. This is carried from a rat. So this is one of our viral infections from rats, which is similar to our bunya viruses in the United States. And you will come across those in our respiratory section, such as sin nombre virus of our bunya viruses. And pretty much what happens is the rats kind of colonize the homes and food storage areas, and they pretty much humans inhale the rat feces and stuff like that and get this virus. It can cause deafness and spontaneous abortions, respiratory distress and hemorrhagic fevers, and then just bleeding from everywhere. All over the place. So this is one of our severe hemorrhagic fevers that is associated with rat transmission. That's all you should really know about this guy. It's very, very low yield as far as all the viruses we're talking about, but it is still a question that has come up on some of the STEP exams. So now on to blood and lymphatic infections. These guys are actually really, really important. So definitely you should be able to spot these on a stem in addition to their differentials. And most importantly, malaria is very high yield. Not only the treatment, but also prophylaxis. So we're going to kind of really dive into the details on these guys. So malaria, I'm sure from your lectures, you probably have heard about these guys and studied a little bit about them. Let's make this make a little bit more sense. So this is Plasmodium species. It's a protozoal infection, meaning it's a very small organism that has small cellular organelles within them, and it's pretty much a single cell multifunctional eukaryotic cell. And they have several life stages that they can change into, infective stages and diagnostic stages. And then they have defense mechanisms, because the eukaryotic cells, they have a lot of different things so that they can survive. It's carried from this Anopheles mosquito, which you can see up in the top right here. And it's always the females that bite. The males eat plants. So female mosquitoes are always the one that bite us. It's a painless bite at night. And it's usually found, obviously, in Asia and Africa, Pacific and South America. In the United States, it is not found. But it is important because people travel to all these different areas and come back, and then they have the general symptoms that we're going to be talking about in just a second. The 4 types that we're going to be discussing are Plasmodium malariae, falciparum is the most important, vivax, and ovale. So the symptoms, how they present, and you definitely need to be able to recognize this right away on a stem so that you can continue with the question fast and save yourself some exam time. The most important thing that you can spot out in a malaria infection is that they have this fever that repeats every day or every few days. They have this cyclical fever where it goes spikes in fever and then it cools down to a low, like non-existent fever, and then they sweat a ton. And then it goes back up, comes back down, sweat a ton. Goes back up, comes back down, sweat a ton. This cyclical stage and repeating is very, very kind of almost diagnostic of malaria, or at least pushes you to go, maybe I should look at their blood and see if they actually have malaria, or ask them, have you been to Africa or India or Pacific or South America recently? Other things, you can see headaches and anemia, splenomegaly can show up, jaundice, even because you're popping some of these cells. Retinal hemorrhage is possible as well, and some of these other guys can show up. So pretty much what you're going to see most commonly is an anemia with splenomegaly, fever repeating, and they feel ill. Those are going to be things that really point you, this person has malaria. They feel ill. The fevers repeat over and over. Maybe they're coming in on the 6th day and they said, I had one 3 days ago. And then since then it hasn't been high. And now it's back up high again. Those sorts of things are really pointing, maybe they have malaria. So what do you do to diagnose? You can do a thick smear. Pretty much when you do a thick smear, you just say, are there spots inside RBCs, right? Are there little things inside RBCs? I don't know what it is, and I don't care what it is inside right now. I just want to see, is this person infected possibly with something? Once I see a little spot or something inside my RBCs, then I do a thin smear to diagnose exactly what is in this RBC. Is it Plasmodium malaria? Is it Plasmodium falciparum, vivax, or ovale, or even another infection entirely, Babesia, which we'll be covering in just a little bit. So how do we diagnose? What do they look like? So these trophozoites is what we call kind of the feeding stage. So when these guys are floating around inside our RBCs, we call them trophozoites. And they form these little ring-shaped things. They almost look like a little bead, and then they form this ring, and then here's the RBC it's in. And so you might see 1 or you might see 2 in there, and they have this little ring. It just looks like a signet ring inside an RBC. Right? We talked about signet rings, I'm sure in histology you've heard about them in regards to adipocytes and stuff like that, but this is just a ring inside an RBC. And that's one of the diagnostic things for malaria. In addition, keep in mind that Babesia has those as well, but I'll be pointing out the difference. There do not have cross structures. It's just like these rings, or like you're looking at the RBC and it has like a weird shape we'll be discussing in just a second. Some of the RBCs can change like shape. So vivax and ovale can change the size and shape. So they make like a very large RBC. So like ovale makes them oval. That's why we call it ovale. In addition, you'll see these little spots all over in the cytosol. This is known as basophilic stippling, also known as Schuffner stippling, and that's found associated with vivax and ovale. Those are the two that cause that basophilic stippling. In regards to vivax, what it looks like, it makes the RBC very large, but it's like square or abnormal shape. I'll be showing you those pictures in just a second. So let's talk about the life cycle of malaria. This is very important to know kind of the time frame of how these are organized, what you'll see at these different time frames, and then what are like the infective and diagnostic and possible spreading stages. So to start things off, the most important to understand is someone's infected with malaria and a mosquito comes and bites them. So we're going to start right here at the bottom. This mosquito comes and sucks out these gametocytes. So gametocytes are the ones that get sucked up by this mosquito, and they actually look like this in falciparum. They look like little bananas. That's what these gametocytes are right here. They're little bananas found within RBCs. And the mosquito sucks it up, and it changes throughout these stages that I really don't care about, and neither should you. However, it gets to a point known as a sporozoite. This is after 5 days after they've developed, and they develop into sporozoites in the mosquito. So this is 5 days. 5 days. They are now sporozoites. This is infective stage. This is the most important thing you should know as far as infection of malaria is that sporozoites are your infective stage. So a mosquito then flies over to another human and starts drinking their blood and spitting out our sporozoites into this new person. Within about 30 minutes, it makes its way to the liver cells and stays there for a total of 8 days. So 5 days, 8 days. We are already at 13 days. 13 days from someone being bit to giving it to a new person, right? So that's 13 days to pretty much get to the point where we can start releasing our merozoites. So what are merozoites? So pretty much merozoites are pieces of these malarial protozoals that can go and infect RBCs. So in the liver cells, these kind of merozoites build up into a kind of a bloated cell that's ready to pop. This is known as a exoerythrocytic schizont. The way I kind of remember that, what a schizont mean is just like an overfilling cell that's about to blow up. And so you're like, oh, schizont. And so a schizont is just about to pop, right? So you're worried that it's going to pop and you're like, oh, schizont. So that's your schizont. So once it pops open, these little merozoites fly out and they make their way over to RBCs. Once they get into RBCs, they replicate for a day and a half. They pop out and infect more cells for another day and a half. So 2 day and a halves equal 3 days. And now we can then shuttle off into gametocytes and repeat the cycle. So the time frames are very important, knowing that it takes 5 days in a mosquito, 8 days in the liver, 3 days in RBCs before we have more gametocytes to be picked up from mosquitoes. So this is kind of the total cycle right now. So I could ask you questions starting right here. Someone gets infected with sporozoites. How long will it take to present symptoms, one, or to be able to infect another person? Meaning, how long will it take from being infected to come all the way back to being infected, infecting another person? So if I were to ask you that question, when do symptoms present? Symptoms present after 3 days of our erythrocytic phase. So that means I get infected with sporozoites, I go 8 days plus a day and a half plus another day and a half. And so that is on day 11, I present with symptoms. Day 11, symptoms. Day 11, symptoms, symptoms, day 11. At day 11, I can make gametocytes and pick up another mosquito. And a mosquito can pick these guys up. Takes 5 days, and now they can reinfect someone. So day 11 is symptoms plus 5 more days. 5 more days, right? 16 days until someone can get reinfected with a sporozoite or with malaria. So careful. They will say, someone just got infected with malaria. Someone just got infected with malaria. How long will it take for another someone to be infected from this person? The answer is 16 days or more. You will probably have an answer choice of 15 days. That's pretty close to 16. However, will this person be infected on day 16? No, we will probably be at the oocyst phase and not the sporocyte phase on day 15. So this person cannot be infected with an oocyte. So at that point, that answer would be incorrect. So look for questions or answers that are 16 days or greater. So if it's 17, 18, 19, 20, those days, it's now possible to be spitting sporozoites into a new human or a new person. So keep that in mind. Those timeframes are very important. Understanding these stages are as well. So what are the species specifically? So Plasmodium falciparum is the most important one that you should definitely be knowing. In addition, one of the most highly yield questions as far as treatment goes and epidemiology studies and all those things come into play. It's the most dangerous as well, and that's why we emphasize it so much. The fever cycle that it has, it repeats every single day. So I mentioned before that we have that repeating fever, right? Fever, no fever, chills, and sweating. Fever, chill, sweating, fever, chill, sweating. This occurs throughout a day, right? It could be every 6 hours or 12 hours that this cycle continues over and over and over. It goes up and down really, really fast. That's more commonly found with falciparum. This guy can also involve the cerebral vasculature. It sticks to it, and that causes obstruction and decreased blood supply to the brain, and that causes cerebral malaria. So it could be hypoxia, unconsciousness, coma, and death that can be coming from this guy. It does not have hypnozoites, and you're probably going, what on earth is a hypnozoite? So a hypnozoite is kind of this bleed-off phase from schizonts. So liver replicates our guys for 8 days, but then they kind of get stuck. They go into this dormant phase. This is called... or dormant phase. Sorry, this is a D, dormant. This is known as a hypnozoite. I don't know what I'm writing there. Hypnozoite. And this is kind of the dormant phase from our liver stage. So that is only found in vivax and oval. And so your falciparum does not have hypnozoite. And we call that exoerythrocytic, or outside blood, which is really stupid why we refer to that, but that's what it's called. Also can cross the placenta, infect in baby, and there's this high drug resistance around the world, especially to chloroquine, which is our #1 treatment for malaria, but there's a lot of resistance to it, so we have to use a lot of different drugs. This is how we look at it on blood smears. So this is a thin smear, and we can see our RBCs up here, and you see these little rings. See, here's the little signet part right there with the little ring in them, and I don't see any crosses. It's only ring structures found within here. The RBCs are normal size and normal shape, and so this most likely is falciparum, and that's how I can diagnose that one. Where vivax and oval, remember I mentioned they increase the size of the RBC and they make weird things, and they have that stippling. You can definitely see those with those two pictures right there. These two actually can form the dormant stage in the liver. This is known as a hypnozoite, and how we treat that hypnozoite is we give them primaquine. So chloroquine can clear all the blood stages of this guy, but hypnozoites is this dormant, and it can appear, and so we can treat the blood stages of someone that has vivax, and they'll be like, oh, I feel great, I'm totally fine. And then 2 weeks later, they start showing symptoms again, right? We give them chloroquine, it goes away, and they're like, I feel fine. And then 2 weeks again, they start showing it. It's like, maybe they have vivax or oval. Give them primaquine. It kills the dormant stage in the liver, and there's no more reoccurrence of this. The stage of fever is every 3 days it has that. So, third and sixth day, they have that fever recurring. Just like we talked about as well. The oval shape and the vivax, I looked up what vivax meant, and it meant something else. So I'm just going to say vivax means odd shaped and enlarged. So it's odd shaped, it has these weird things in it, and it's got that stippling. See how it's very large? That's our P vivax. In oval, we see an oval shape, we see the stippling, and it's enlarged. I have ovale. That's how I can diagnose those guys. Plus the fever, possible recurrence, give primaquine, and that gets rid of that. Malaria is the last guy that you should be knowing. It presents similar to vivax and oval, except the fever occurs every 4th day. There's no hypnozoites for this guy or exoerythrocytic stages, and they're kind of diagnostic on this band-shaped thing. So you see this band going across the RBC. That's P. malariae. In addition, you can see these weird little rosette schizonts in the RBC. So this is what like the schizonts look like in these guys, and they're ready to pop out of there. Oh, schizont. Yep. Okay. So a little bit about treatment. I'm not going to go too much into detail. This is a great chart to explain how to treat malaria. I just want to emphasize kind of, you have discussed adverse effects and some of the important drugs, right? So if you have uncomplicated, unresistant malaria, just go for chloroquine. That's your answer. However, if you have some sort of resistance, you want to jump it up to something a little bit better. So look for one of these guys here. If it's Vivax or Val, remember they can have hypnozoites hidden in the liver, so you got to get rid of them with primaquine. Primaquine is going to get rid of that Vivax and Oval hypnozoites. If there's super resistant stages of any of these guys, you can give quinine or quinidine. This is kind of an antiarrhythmic drug, but we found out that it actually kills off these guys. But pretty much the really resistant guys, you can give quinine. That's our kind of go-to last possible drug. When it comes to prophylaxis, on the other hand, in pregnancy, we can actually give chloroquine, so that's the best drug. If they have Ovale or Vivax, do not give them primaquine until they deliver the baby. Then you can give them primaquine. In addition, mefloquine is one of the best prophylaxis for pregnant women. This is one of the best guys for that. They mentioned in your lectures, and it's not necessarily true, but Malarone, this is also known as Atavaquone and Proguanil. These are the best prophylaxis overall out of everything, right? So mefloquine is the best for pregnancy, and it's cheap, but overall best prophylaxis for everything is known as Malarone. But knowing Malarone is not enough. You actually need to know that it's Atavaquone and Proguanil. Just pronounce it with an accent or something like that. Atavaquone and Proguanil. That's how I remember that those guys are the best at prophylaxis. So again, uncomplicated, go for chloroquine. If she's pregnant, go for chloroquine. If it's resistant, pregnant, go for mefloquine. If it's super, super resistant to everything, go quinine. Best prophylaxis, Atavaquone, Proguanil. That's pretty much all you should know. This chart should come in handy when you get to pharmacology in term 5 for these guys. But I just kind of wanted to put a little bit spin on what's emphasized important from this guy. So now on to the last few of our infections as far as the blood. Babesia is another guy that comes up. He presents very similar to malaria, except this is actually found in the United States. So malaria is not found in the United States, but this is. This is carried in the northeast United States by the Ixodes tick, also known as Ixodes scapularis. So if you were to say, where is Ixodes scapularis tick found, which is this little guy up here, right? This is our Ixodes tick. You can say, oh, well, he's found in the scapula of the United States. And you go, what do you mean scapula of the United States? Well, don't you see that? I see a scapula right here, right? There's a scapula of the United States. That is where we actually find this. So the northeast United States is where we find Babesia. And it also makes sense because a lot of students I've met actually know that Lyme disease is found in the northeast United States. And isn't that weird that this is the same tick that carries Lyme disease, also known as Borrelia burgdorferi. We will be coming across this infection in our multi-system, so don't worry about that guy right now. I just want to emphasize that Babesia is another blood infection that looks like malaria, but in a stem, if they're wanting to pick out Babesia, this person has not traveled to anywhere you're going to get malaria. They probably live in the northeast United States, Massachusetts, Maine, those sorts of places. And have symptoms of fever and chills, malaise, anemia, One weird thing about this is you can find coarse lung crackle, so it causes pulmonary edema. ARDS is possible with this as well. And then one other thing is splenomegaly, which we saw that in malaria as well. And that can decrease your RBCs, causing anemia, and platelets, which can cause bleeding via the sequestration process. Differentials, like I mentioned, is malaria, except Babesia doesn't have recurring cycling fevers. This person's going to be feverish the entire time. They're going to feel terrible. They're going to have lung crackles, enlarged spleen. They live in the Northeast United States. And then on peripheral smear, we don't only have just ring RBCs, right? Our ring RBCs we saw in malaria, but we also see these cross-shaped, also known as our Maltese cross, intraerythrocytic inclusions. So you can see this kind of cross being formed right up here, and this guy right here, this is our Maltese cross found in RBCs. That, bam, is Babesia. That's how we diagnose this guy. I put up a couple of the species names. I really don't think they're that important. Just recognizing Babesia is the important part. Now on to our lymphatic infection. So Werkaria bancrofti is pretty much, you've probably have heard about this guy. This is known as lymphatic filariasis. This is found in Africa and India and Asia, and it's transmitted into a human at the stage of L3 larva. That is actually really important to know, that the L3 larva is the one that is infective stage. The diagnostic is an L1 in a thick blood smear at night, or we can just simply do this new test we created known as the female antigen test, or immunochromographic test, which is the gold standard nowadays. We don't have to do it at night. And you might be asking, why at night? What do you mean by this? So in basic microbiology, you might have heard about some organisms that only come out into the peripheral blood so that we can actually detect them at certain times of day. And this is probably because these organisms recognize that we were only being picked up by mosquitoes that were biting at night. Therefore, why would I be putting myself flying around in the blood, being able to be picked up by my this person's immune system and killed off? Instead, I want to spend my energy to kind of secrete out my babies into the blood so that they can be picked up only when these people are being bit by mosquitoes at night. So diagnostic for this guy used to occur only at night. During the day, we weren't able to detect it because the worm wasn't secreting out its eggs into the blood, or this L1 larva, I mean. And so that's kind of this weird phenomenon that occurs with Werkaria bancrofti. So what is the disease that it causes? It can cause chyluria, or lymph in the urine, hydrocele in men, and then more commonly the lymphatic filariasis. It just goes up, hangs out in the lymph system, and causes obstruction, lymphedema, and then eventually that swelling into the tissues can cause chronic inflammation, and then we can have fungal and bacterial infections on top of this. This is known as recurrent filarial fevers. If we wanted to treat this person's filarial fevers, we just treat those bacteria and fungi instead of the actual worm itself. And eventually, after a long amount of chronic inflammation, this leads to elephantiasis. I really didn't want a picture of that because it's kind of gross, but I'm sure you are traumatized from what elephantiasis looks like. So that is something that we can stop if we treat this worm right away, that if this person has it. In addition, there's some important information as far as how we can actually treat this. So this weird thing, this organism, this gram-negative bacteria known as Wolbachia, actually lives inside this worm. So you can see these little spots over here in the worm. Inside there, that is actually Wolbachia itself. And these guys, what they do is they help this worm undergo like sexual reproduction. And without those bacteria being present, there's no longer an ability for this worm to replicate. And so if we can kill off those bacteria, we now make a sterile worm. And then once this worm dies, then we stop the disease. Wolbachia is also found in another organism, Onchocerca volvulus, and when you guys see that guy in multi-systems, you will be able to see its little spots. It looks like a leopard worm, and that's also Wolbachia found within that as well. And so the treatment is driven towards a few things. For filarial fevers, again, bacterial and fungal treatments, right? Like topical fungal fungicides or bacterial antibacterials. If we want to kill the Wolbachia itself, we give doxycycline. If you want to kill the worm itself, it's diethylcarbamazine, or DEC, or DEC. And so the way I kind of remember this, my friend kind of came up with this. It was actually really good. There's two worms. There's another worm. It's called the eye worm, or wormy worm is what loa means. It's just some other worm. You'll learn about it in our multi-systems as well. But Loa and this worm, Werkaria bancrofti, are both targeted by the drug diethylcarbamazine. They're the only two worms that we really treat using diethylcarbamazine, or DEC, right? So if you can just think, deck the halls with Loa, filariasis, then you can remember that Loa and filariasis, or lymphatic filariasis, as we have here, are both treated by DEC, or diethylcarbamazine. That's going to definitely help you with pharmacology for those guys. And again, I want to emphasize this for the third time: recurrent filarial fevers, bacterial and antifungals. Do not miss that free point. All right, so let's go ahead and continue into the last section that we have, and that is cardiovascular microbiology. I'm aware that some of the subjects have been rearranged. This is just the completion of my microbiology modules. However, this is the first module that you're going to be covering as far as microbiology is cardiovascular system and how that affects the populace in our hospitals and those out in the community as well. So without further ado, the first thing in how you approach cardio, this is actually one of the easiest sections that it's taught the worst. And so how about I teach you better so that you can learn to approach these questions. So the first thing you kind of want to look for in a STEM that's leaning for cardiovascular infections, such as endocarditis, for example, are your risk factors. Those really give you the exact diagnosis. So pretty much it's going to be someone that comes in. So let's use this example right down here. We have a 50-year-old man that comes in. He presents with 2 days of fever at 103 Fahrenheit. This means this person is probably ill with some sort of infection. We don't know what it is. However, once we get past the fever, he's fatigued and malaise. So this is probably something to do with either the GI tract, he's losing fluids, or something to do with blood, or possibly heart. We've now kind of narrowed down our differentials as those usually the things that involve these sort of symptoms right here. It still could be a respiratory infection. It still could be other things, but just based on that right there. So once a person comes in, he's complaining of that, I get my stethoscope out and I listen. I hear a new murmur. This is one that has not been present in the last patient's visit. So at that point, I have this person feels ill. He has a fever. He's tired. And there's a new murmur. At that point right there, being that he's 50 years old, it screams to me he has some sort of infection in his heart or in the cardiovascular system. Most likely at this point, since there's a murmur, it's most likely the heart, being more specific, and that is probably endocarditis. That stem base right there screams to me. So again, the first thing is you want to know your risk factors, which we're going to be going over. Don't worry, we'll get there. Plus the basic stem that they usually present, trying to say this is endocarditis. You put the risk factor, plus the basic symptoms in the stem. You have your diagnosis, and you continue answering just whatever the specific question is looking for. Being that you're in microbiology, they usually like to ask you detailed things about the organism that is most likely causing this person's infection. And so that kind of comes down to what is the most likely organism for each of the risk factor types. So that's why, again, risk factors are very, very important for this. So the first things that you kind of can do if you want to break down and study endocarditis is you can break it down sort of like how you most likely have learned it in lecture. And I'm going to kind of do that a little bit, but really focus on those risk factors. so that you can really pick out the correct organism for it. However, how we do that, I don't want to just leave that blank there, is you can classify it via like acute versus subacute. You can base it just on the risk factors themselves, such as someone that has dental procedure, or they're an IV drug user, or some old person with colon cancer, or they had recent GI surgery or prosthetic valve. And those kind of things are what you can organize what is the most likely organism for it. And I'll show you how we go ahead and do this. So for infective endocarditis, before we do those, I kind of want to do, what is it, right? Sure, it's infective and it's in the endocardium, but what does that exactly mean, right? Our heart is constantly circulating blood, so how on earth is something sticking to the inside of the heart? Well, it kind of comes down to the specific organisms that can cause this. Not every organism can actually cause this, so there's kind of special things about each of the ones that do. So usually when we're talking about this, we're usually not talking about like the ventricle wall necessarily. We're usually talking about valves. Valves are the most commonly associated things in regards to infective endocarditis. If you're on the left side of the heart, it's usually things such as strep, for example, strep coming from plaque in your teeth. So if you ever heard of someone like, oh, if you don't clean your teeth or brush your teeth or floss your teeth, that plaque can make its way to your heart. What I used to think that was as a kid was thinking, old people have blood clot or atherosclerosis, right? I might have heard of that, and I didn't know exactly what it was, but I thought that plaque actually came from your teeth. So that kind of scared me into brushing my teeth as a kid. It wasn't the reason or the argument my parents had to me when I was a kid, like, you better brush your teeth or you're going to have atherosclerosis. No, they never said that, because I didn't actually know what that was, but growing up, learning a little bit more about science, that's what I thought. I thought that plaque from your teeth led to atherosclerosis plaques, but that's not necessarily true at all, actually. It's the plaque of your teeth or organisms, especially strep, like mitis. It's your viridins group. And strep viridins group, if it can get into the blood, if there's some sort of underlying damage or something it can stick to, it will. And so it makes plaques, or also known as aggregations of these colonies growing on the endocardium or on the valves, and this is known as infective endocarditis. If it's on the left side, again, it's usually strep. The exception is staph endocarditis, and that is usually on the right side of the heart, and that's tricuspid, and it's associated with IV drug use. If you have someone with that basic stem of something that's screaming to you, this person most likely has infective endocarditis, and it is on the right side of the heart. Just pick staph. Done. You don't need to pick anything else unless they tell you a lab result, like we did a culture and it grew like this, and those results say it's not staph. If that is what actually is added into the stem, if that isn't in the stem, just pick staph. But if something else says, oh, it's actually strep for some weird reason on the right side of the heart, then obviously pick strep. But if, in particular, they don't give you labs and they just say it's on the right side of the heart, IV drug user, done. That's Staph aureus in specific. So the two types of endocarditis we can talk about is acute versus subacute. So in that stem before, high fever, feeling of illness, new murmur, that's acute, especially if it's acute onset, like, oh, he's only had it for 3 or 4 days, he's been feeling real ill. The key feature here, though, is high fever and new auscultation. It usually occurs within a couple days. Where subacute endocarditis, usually this person has previously abnormal valve, some sort of other risk factors we're going to be talking about in just a second. Usually low virulence things, so they're going to have really like a low fever. It's going to last a few weeks and they'll be feeling ill and stuff like that. So again, for endocarditis, it's got to meet the Duke criteria, which we'll talk about, and kind of the symptoms that come along with that. As far as risk factors go, there are particular ones and they're associated with particular organisms. So we'll go ahead and kind of talk about these guys, or a few of them at least. So when we're talking about mitral, like risk factors for already damaged heart. So in the United States versus in the throughout the world, there is a difference. So usually what has to happen for infective endocarditis, and the most common presentation of infective endocarditis is usually the subacute endocarditis is the most common, and how it presents is usually someone that has a recent dental procedure. So they just got a tooth extracted, they've got a crown on, something that leads to a little bit of bleeding in the mouth and letting some of that strep organism kind of leak in there, make its way in circulation, make its way to the heart. But again, like I said, there has to be some sort of underlying damage. So what is that underlying damage depends on where you are. If the stem simply says, a 35-year-old woman that comes in, something like that, and doesn't say that she ever lived out of the United States, then we're assuming she's from the United States, and my most underlying cause and pre-exposure damage to the heart or a valve of a native valve would be mitral valve prolapse. So if I were just left with a basic stem from someone we're assuming is from the United States and they have subacute endocarditis, especially on the left side of the heart, I'm assuming this person has mitral valve prolapse. It is the most common cause of underlying basic infective endocarditis heart damage that we already have. So it's just kind of, it's now opened up a nice field that we can grow all our bacteria on. Our damaged field, sort of, is what our mitral valve prolapse comes with. Now, if we're talking about in the world, especially outside of the U.S., if someone's coming from India or Africa or something like that, strep pyogenes, or strep throat, as you might know it as, is a very common infection. They're not treated very well in a lot of these countries, and so this leads to rheumatic heart disease, which you probably have heard about in PATH and studied. And at this point, you should know a lot about this. So this pre-exposes or damages valves, especially the mitral valve, on the left side of the heart are the most common locations. And so rheumatic heart disease is the most common around the world, especially outside of the United States, that damages native heart valves, allowing for strep viridans group to come in. And viridans is also the one that comes up on mitral valve prolapse. So strep viridans, right? And how I would describe that is a catalase negative organism. We will be describing each of these individually. Now, other things can lead to damage to your heart valves. Obviously, really, really, really old people can have calcified, like aortic stenosis or calcified valves, and that can lead to this as well. That's less common, and you're probably not going to get a question involving that. So look for really rheumatic heart disease for someone that's an immigrant, or mitral valve prolapse for someone from the United States. Other things are prosthetic heart valves. We'll be talking about those in just a little bit. This is associated with staph epidermidis infection. So this is something that when we put in a new valve, we give them staph, especially epidermidis. It comes off the surgeon's arm, makes its way onto the valve, and then we install it. We start up their heart, and we go, have a nice day. 3 weeks later, the patient comes in feeling ill, low fever, new murmur on auscultation, and they meet the Duke criteria. They have subacute endocarditis. We just put in a prosthetic heart valve. What is the most likely organism? That is staph epidermidis. That's how we describe that one, is the most likely. IV drug use, like we said, it's usually the right side of the heart, associated with Staph aureus. And then anything that can lead to bacteria in here. So cuts, surgeries, dental procedures, all these things. Obviously, I can't have infective endocarditis without the actual bacteria or the organism doing it. So if I don't have bacteria floating around the blood, they're never going to make it to the heart in order to cause infective endocarditis. So I have to have some sort of transient bacteremia. So look for surgery or dental procedures recently, or IV drug use. Those are the things that we're usually talking about for an infective endocarditis question. Other things, a very rare case, and this comes up actually in our multi-systems thing, so keep an eye out for that when we're talking about zoonotic infections. But if you have like a farmer, a rancher, a butcher, or something like that is associated with animals or cutting them up, then it could be Coxiella burnetii. Again, this is very low yield as far as your cardiovascular stuff right now, but when you get to multi-systems, it actually comes up to very high yield because it is the most common cause of zoonotic disease to affect the heart. But I just want to mention it here now, so this name will ring a bell when we get to multi-systems. So a little bit more about infective endocarditis. So if we were kind of to break down these guys, now I want to associate a particular risk factor with the organism. So this is how questions are going to go. They're going to give you that basic stem as we described. You're going to go, this is infective endocarditis. At this point, you now have to go, what is the risk factor for this question? And they're only going to give you one. They're not going to say this person has a prosthetic valve, IV drug use, dental procedures, colon cancer, and GI procedures as well. They're not going to give you all 5 of these because that would be an impossible thing unless they gave you lab results. So I'm going to give you both. So if I have a prosthetic valve, I mentioned that this is Staphylococcus epidermidis. And how do I describe this? So remember our staphs versus our streps. That our staphs are catalase positive. Our Staph aureus is the only one that is coagulase positive, so epidermidis would be coagulase negative. And how do I separate epidermidis from saprophyticus? I have to do one additional test. This is my novobiocin sensitivity. It's an antibiotic I put in my media. If it grows, then it is resistant. If it doesn't grow, that means it's sensitive and dies because of the novobiocin antibiotic. And just keep in mind that your epidermis is very sensitive, right? Your skin is very sensitive. And so I know that Staph epidermidis is sensitive to novobiocin. How I remember the opposite, the one that is resistant to novobiocin, is saproresistant. So this is Staph saprophyticus is saproresistant. That's how I remember that guy. But for prosthetic valves, Staph epidermidis, catalase positive, coagulase negative, novobiocin sensitive, and other things that can cause infections on prosthetic valves are gram-negative bacilli, but don't worry about those too much. I just have to put it there because it is sort of important, and you can possibly get a question on that, but very unlikely. They usually want to point out epidermidis. So that's prosthetic heart valves. Now, for someone that has IV drug use, I know I'm kind of beating a dead horse here, but Staphylococcus aureus or Staph aureus. This usually is acute, so this person's going to have a high fever. It's going to be quick onset, and it's usually associated with a tricuspid native valve. So we haven't done anything to the valve. It's totally fine. I could get Staph aureus infective endocarditis. My heart is totally fine if I were to do IV drug use, right? I can increase the risk of getting this guy. This is, as you know, Staph aureus and some of the other big organisms. These guys are very pathogenic, so they don't even need a damaged heart valve or damaged tricuspid valve. They just need to be flying around in the blood. So that's all that they require in order to cause this. So it can be a totally sharp baby heart that could be infected with Staphylococcus. Hopefully that baby is not doing IV drug use. But anyways, dental procedures is the next guy. So dental procedures, I mentioned, is your Viridans group. So you want to actually be able to recognize some of the basic organism species names. So S. mutans and S. mitis, that is actually more high yield than just being able to separate Viridans. Actually knowing the species names is very important because you have to pick them from some of the organisms, and you're just going to be like, what is S. mutans? I've never seen that in my life. Unless you now listen to me right now saying you actually do need to know this. Usually associated with subacute on a native valve, but one that is damaged. So someone that's like really old, rheumatic heart disease, or mitral valve prolapse. Remember what I just mentioned on the previous slide. If I were to describe this group of organisms, there are particular things you should know. One thing is, if I were to ask you a question, I have this person who just did a dental procedure and they have endocarditis. The organism most likely to cause this produces what in order for it to actually stick or to bind to the surface of the valves and the endocardium? At that point, your answer should be this: something associated with biofilms. And those things associated with biofilms are known as dextrans. They take sucrose and glucose, break them down, rebuild them as dextrans, and that adds kind of a sticky. So if you can take a little bit of sugar and you get it a little bit wet and then let it dry, it gets really, really sticky. This is kind of what these guys do on their surface. They break down sucrose and glucose. They wet it down almost like that and then stick it on their surface. Now they're kind of sticky. So when they fly around in the blood, they can stick to exposed or damaged heart valves. And that's exactly what they do. Not only on the heart, but actually how it gets on your teeth. So you might be wondering why plaque is kind of hard to scrape off and why you need to go to the dentist every 6 months so that they can scrape off these biofilms, is because these guys produce dextrans. They use the sucrose and glucose that you ingest in order for them to grow and stick to your teeth. And that's why they grow so fast and why you can get all that plaque by the end of the day and stuff like that, which is gross. Anyways, how do we describe the virulence group? So strep, remember, versus staph. Strep are catalase negative. This one in particular is a group found within your alpha hemolytics. The other alpha hemolytic is something that has a capsule, and it is your diplococci, lancet shaped. I'm sure those kind of names might come up again and again in respiratory. You're never going to hear the end of this guy. This is known as your strep pneumo. But this guy in particular is alpha hemolytic and has no capsule, unlike strep pneumo. And then this is optochin resistant, so it will grow on optochin agar, where strep pneumo, on the other hand, has a capsule, and that's what we make the vaccine for, right? Our vaccine is the capsule antigen, and it is optochin sensitive. If you watch Sketchy, you'll get that kind of locked in there. If someone has colon cancer, or if they give you the diagnosis, this person has infective endocarditis with strep galelicus, also known as strep bovis for butt cancer, this is your colon cancer is what you want to be looking for. This is actually super high yield to know. It's very interesting. It's very rare that this happens, but if someone has infective endocarditis and they give you the diagnosis of galelicus, also known, it used to be known as strep bovis, with these guys, you have to know that there's some sort of underlying colon cancer, and you got to be looking for that. So they can actually ask you, what should we be looking for if someone has this? And that's do an endoscopy, all right, do a colonoscopy in order to see if they have colon cancer or some sort of cancer in their GI tract. That has the same labs as enterococcus, except it doesn't grow on NaCl, and we're going to be describing that right now. So if someone has GI procedures, right, we talked about GI cancer particularly. This is actually GI procedure. So someone has appendicitis, or they have a tumor, and we go in for surgery to actually cut it out, right? We're actually cutting the GI tract open and then sealing it back up. That exposes the person to group D strep, also known as enterococci. And so the way I remember this is catalase negative. It's gamma hemolytic, along with your bovis, right? Both of these guys are gamma hemolytic. And with that, the differentiating factor is that your enterococci, or group D strep, can grow on NaCl and bile, where butt cancer can only grow on bile and not on salt agar. And that's how I just kind of organized risk factor to disorder. And this is how your questions are going to be showing up. Person has endocarditis, recent dental procedure, they had strep throat multiple times as a kid, and they have had a murmur in their heart for a while. Now they have a new one. What's the problem? At that point, I know they have rheumatic heart disease, so their heart was already set up to kind of capture anything that's floating around in the blood. And this person just had a dental procedure, was my risk factor. Put those things together. Strep viridans, be looking for mutans or mitis. Those is pretty how straightforward these questions are. There's no weird organization that you need to do. If you just follow this, you'll be able to answer these questions. So, we've already talked about, there's abnormal blood flow due to some sort of damage in the endothelial lining, or the blood flow changes the endothelial lining. Somewhere along the lines, these guys occur first. And that allows for the binding of via fibronectin of these organisms, especially viridans group. They use dextrans to bind that fibronectin. And at that point, that is where we have infective endocarditis. Now, symptoms that come along. There's specific things that you need to kind of organize, and I'm actually giving you a head start on your pathophysiology, and this should get you a question in term 5 in regards to your pathophysiology exam, but this is something you should know even for STEP. So I want to teach it to you now. You're going to learn it again in term 5. When you get to STEP studying, you'll go over it again, and then when you get to STEP, you'll get that question on the exam correct as well. So I want to get you the exposure of this. So with infective endocarditis, there are all these different things. We already talked about fever, so let's cross that off, leaving us left with these other random things. We talked about new murmur, especially regurgitant murmurs. So let's go ahead and cross that off. And that leaves us with these other things: Janeway lesions, ossular nodes, splinter hemorrhages, anemia, and Roth spots. So what are these things, and how do I describe them, and what is the organization of them? So Janeway lesions, I just remember that Jane wouldn't hurt anybody, and so these are non-tender. Non-tender, they're very small vascular lesions, and they're hemorrhagic. So pretty much what happens is there's some sort of embolization, and that cuts off blood supply. There's necrosis behind it, and then we reperfuse. This leads to a small, non-tender hemorrhagic lesion. It usually is in the palms and soles of the feet. So if I were to ask you, what are the infections that lead to a rash or something showing up on the palms and soles, you have to add an infective endocarditis onto your differentials. And when you guys get to skin, you'll learn all the other guys. There's only a few, which is good. This kind of really narrows down to pretty much 4 options to pick from that lead to palms and soles involved. So if you see those 4 things, be thinking of infective endocarditis. When you get to skin, you'll learn of the other 3. But as for now for your first exam, this is great. You see palms and soles, you're talking about Janeway lesions. That's infective endocarditis. Now, ossular nodes. These guys are O of ossular for ouch. They're very painful. This is immunological response. It's red, raised lesions in the hands and feet. And this is immune complex deposition. So Jane wouldn't hurt anybody, non-tender. Ossular nodes. This is painful, ouch, of ossular. And this is due to immune complex deposition. So immune response is responding. There's swelling and redness. And so associated pain would be coming with that. Splinter hemorrhages. This is vascular, obviously. We have some sort of necrosis occurring under the nail bed. Then we reperfuse, and that leads to a little bit of hemorrhage. Anemia can occur. So if I have these valves kind of sitting out in the path of where my blood is usually laminarly flowing smoothly through across these valves, if something's in the way, I have a turbulent flow, and the blood cells can shear off these valves, and that can lead to anemia. Other things of Roth spots, so R of Roth spots is what you're going to find in the retina. And again, this is immunological. So if I were to say, what are the vascular lesions? We're going to be talking about Janeway and splinter hemorrhages. If we're talking about immunological, you're going to be thinking about retina and specifically the painful ones on your hands and feet called ossular nodes. This is very important to know which ones are vascular versus which ones are immunological, and be able to recognize which of these. And that's pretty much part of the main purpose of your diagnosis of the Duke criteria. So Duke criteria kind of checklists. Oh yeah, he's got this and this and this, new murmur, right? And a fever, and he has a risk factor for it. Bam, this guy has infective endocarditis. It's just kind of a diagnostic criteria. But all these things, or maybe 1 or 2 of these things, can actually show up in the stems as well, giving you extra support for your diagnosis. So this last kind of group is really weird. I don't like these guys, but there are a few things you should know, and I pretty much shortened them so you don't really have to study a lot. So your HASIC group, these are your culture negative. So if I draw out someone's blood and they have infective endocarditis, nothing will grow on any of my augurs. So you're probably asking me, how do I know this? Well, I can still do other tests and run other tests on them. Now, keep in mind, there are some ways that we can actually grow them. What this culture negative just means is it doesn't grow on the normal augurs that we usually test with. There's special ones for this organism, right? This is Aggregatobacter. These guys grow cigar-shaped colonies. And the way I just remember the diagnostic for these, pretty much these 2 are the only ones you really need to know. Eikenella and Kingella, I don't know anything about them, and neither should you. Just know that they're gram-negative organisms. Haemophilus as well, but that usually comes into respiratory infections. So as far as the heart, Aggregatobacter and Cardiobacterium are the ones that you really will need to focus on and be able to differentiate amongst them. And so the best way to do this is, I just remember aggregators eat cats, and so therefore aggregator bacter is catalase positive. This guy does produce this cytolethal distending toxin, and that allows for biofilm formation. So same thing that we kind of talked about in regards to strep viridins group, making those dextrons, allowing it to bind. This guy uses something else called cytolethal distending toxin. And remember that aggregator bacters, aggregati, eat cats, and so therefore they're catalase positive. Where cardiobacterium, I just remember aerobic exercise is good for the cardio. Cardiobacterium is oxidase positive, right? Because aerobic, oxygen. And so these guys will be oxidase positive, catalase negative, where these ones will be catalase positive, oxidase negative. That's pretty much all you need to know about those guys. So lastly are the few other infections involving the heart. We've already talked all this stuff so far have been endocarditis. So let's go ahead and talk about the other types of carditis. Pericarditis, we're going to knock out first because this is pretty much the easiest. Person comes in with pleuritic chest pain, and you might be going, I don't know what that is, unless you already do know what that is. Let me explain. This is someone that is like super sharp pain, like chest pain. But it's very localized, where someone that has chest pain, like a heart attack, they're going to have like referred squeezing, compression. It's almost like someone sitting on their chest pain that can radiate to the jaw or the left arm. This person has sharp pain. It's like where their heart is, right behind the lung. They feel it like stabbing right there. That is pleuritic chest pain. If I were to take my stethoscope and put it on their chest over their heart, I would hear a friction rub. It's just like, that's what it sounds like. And so when this person leans forward, the pain is kind of relieved. So I just imagine, actually I'm going to draw a beautiful heart. This is my wonderful heart. Here's the heart, and here's the chest wall, right? So I have this space in between here, and I have like a pericardial sac around here. So here's my pericardial sac, here's my chest wall. So this person is experiencing pain when the heart has to swing forward, bam, and smack into the heart wall. So can you imagine them accelerating into a wall? So if you start a mile away from a wall and accelerate in a car and hit the wall, will you be hitting it harder than if you were to start an inch away from the wall and accelerating? Well, obviously, if you're an inch away, you only have to travel this. You're not going to accelerate very fast. You're going to get to maybe half a mile an hour, and bam, you hit the wall. So how painful is that? Well, not at all. You didn't do anything. Now, if you're a mile or half a mile away and you accelerate, you're going to be at 60 miles an hour and smash, crash. So this person with pleuritic chest pain, when they lean forward, their heart is closer to the surface of their chest wall or the lungs, the pleural cavity, something like whatever is in front of the heart, or the anterior mediastinum. It's now closer, so when it beats, it doesn't smack into the anterior heart wall. So that's why the person leans forward. If they lay back, right, or if they're laying on their back, right, their heart has to beat and swing, bam, and has to hit the anterior wall as if they started their car and accelerated from a mile away to drive into the chest wall. So that is why this person has sharp pain, but also why it's better when they lean forward. That is a key finding that you'll find in stems when they're describing pleuritic chest pain, plus the friction rub. Now, if I were to say what is the most common cause of pleuritic chest pain or pericarditis as far as infections, your answer is Coxsackie B, and you don't need to read really any of the rest of this slide. Okay? Coxsackie B, which is a picornavirus, which is a single-stranded RNA positive sense virus. Done. I don't need anything more than that. This should be your studying as far as right here. This is all you should know for STEP. Now, I can add in extra things, right? Staph does everything, so why not throw in staph? Other things like coccidioides can do this as well. This is an infection found in like Southern California or Arizona, Southwest United States. Other things in the middle of the United States and Northeast are histoplasma. You will get to these in your respiratory sections. Don't worry about them as far as your cardio stuff. Just stop when you read Coxsackie B right there. As far as myocarditis, we need to talk about a few other things, okay? Again, most common in the USA, Coxsackie B. Bam, done. I don't need anything else from that point. If we're talking about the world, parasitic, sure, whatever. I'm not really telling you to necessarily study this. I will be sharing and describing those parasites in just a second as the ones that can cause this. But Coxsackie B for right now, it should be the most important thing to you in regards to myocarditis, specifically infecting muscle cells in the heart and damaging muscle cells. There is another infection that you're going to get to in multi-systems that affect the heart, but it's actually the vessels of the heart, like the aorta. But that is usually associated with other things, and so don't worry about that right now. Just focus on Coxsackie B. You can have stabbing chest pain. Literally, the person just comes in and says, I feel like I have a knife in my heart. Very specific, sharp stabbing. And it's not, it doesn't change on position. Where you talked about pericarditis, that does. Now, strep pyogenes. Remember that this guy can lead to rheumatic heart disease and pancarditis. So this can involve your pericardial sac and your myocardium. But keep in mind that that's usually more of a path question than a micro question, but it still could come up. That is a type 2 hypersensitivity. Okay, so parasites. There's a couple that we can discuss. So the first one is Trypanosoma cruzi. This is known as Chagas disease. This guy in far further detail will come up in multi-systems, and I have really fun ways at remembering that, so definitely check out those videos. And we have another guy known as Paragonimus westermini. We'll be talking about that in just a second. Get a whole slide for him. And Baliscaris procyanosis, or a Toxicara species. And then lastly, Trichinella. This is usually a muscle infection, like actual skeletal muscles, but it can involve the heart as well. And that will come up in MSK. So now on to this Paragonimus westermini. This is now your first kind of systems parasite slide that we've come across. And this is kind of not that high yield, but I want you just to be able to recognize it at least. There might be a question on UWorld about it. However, when you get to parasites, we talked about this at the beginning of this video. It pretty much needs to understand, what does the picture look like? What are the basic symptoms and where it usually infects? And then knowing parasite infections in general as far as our immune response, like eosinophils and stuff like that, right? Other things, where we get it from, lastly, and infective and diagnostic stage. Those are pretty much all you need to know in regards to these. And it seems like a lot, but it's actually not too bad if you read it a couple times. So this guy is known as your lung fluke or water fluke. It's found in Japan, Asia, and Latin America. That's not super important, but lung fluke actually is sort of important. You can get it from crustaceans like crawdads and clams and stuff like that, along with hepatitis viruses, as we talked back in the beginning. And then the infective stage is a metacercariae. And then once it gets inside, it grows into this leaf-shaped Paragonimus westermini fluke. And this is this guy right here. I just think of it looks literally like a boogie board, or like one of those little boards that you, like a skim board. If you ever see those guys kind of running on the beach and there's like a little bit, like an inch or two of water, and they throw at this board and they jump on it and surf into the waves. That is actually sort of what this guy looks like. That's Paragonimus westermini. So I just think of the guy surfing out on the west on his little surfboard skimboard thing, and that's enough for me. So diagnostic, pretty much I need to see the fluke. Since it's a lung fluke, it goes to the lung, and when I cough it, you have a fluke that comes out, which I can imagine is the most fantastic thing to find at 3 o'clock in the morning when you start having a cough attack. Actually, no, that would be horrible. Other things we can detect, the antibodies against it or the antigen from the actual worm itself. Eosinophilia, lung infection, chronic cough can come up with this. Again, last thing, it can infect myocardium, and this is why it comes up in lectures. That's pretty much all in regards to this guy. Now, Toxicara species, I like this guy a little bit more. This is an ascarid worm. I don't need to describe that. It pretty much is a worm that comes from dogs. Raccoons are specific to the Balis ones, which we'll be talking about in just a second. And then this is a migratory worm. So this is a worm that once we ingest it, it makes itself through the GI tract, throughout the blood, and then inflames all sorts of stuff. It can cause diarrhea in the GI tract first. It can migrate to organs such as the heart, causing myocarditis, as we talked about. It can go to the liver. It can go to the eye, causing blindness, as you can see in this child right here. Has this big swollen eye right here. This is actually caused from Toxocarus species, and this child did lose their eye to this because the mother did not vaccinate, did not keep her child away from their new puppy that they got, and this child ended up getting that. And then it can cause what is known as neural larva migraines, which means the larva has migrated to the nervous system or CNS infection, and that could be a big problem as well, and that could cause seizures and coma and death. Pretty much what you're going to see with these guys, because it's a worm that's it migrates all over the place. You can see granulomas forming, especially eosinophilic granulomas. And then if we were to break down this disease, so person comes in, they have worms migrating all over the place. They have a recent puppy, bam, like that's it. Like they have a dog, or they have some raccoon that they had to scare off the other day, digging through their trash up in their cabin in Tahoe, California, or something like that. At that point, now we're thinking raccoons or dogs, what can we get from them? We have a worm migrating, child is blind or something like that in the stem, or they have some sort of shortness of breath, something having to do with the heart. At that point, I know we're talking about these guys. So how do I separate them? Pretty much, if it's a dog that the person has in the stem, it's Toxocarus canis. If it's a raccoon, it's Balasascaris procynosis or sionis. I don't really know how to pronounce that correctly, but that's specific for raccoons. This Balasascaris actually is very commonly associate itself with the CNS, but remember, if it's dog exposure, be looking for canis because that also can go to CNS as well. Diagnostic. Serology. We don't look for the worm because I don't want to be digging through someone's brain to be looking for a worm. I look for antibodies. Once I find antibodies, I give them treatment if I can, or I'll sit supportive and kind of leaving where it is. So I just kind of put this cute little raccoon that's sweeping these people's floors. I don't know why these people have a pet raccoon, but I'm sure it's got its rabies shot, so it's probably safe.
All right, so that completes the modules. Thanks for watching. If you want the PowerPoints for this, you can locate that on our Facebook page, CK Med Plus. Don't forget to hit the bottom subscribe button.